Hello everyone. Today we are going to discuss the cardiovascular system, the most important points and the most important notes for the MCQ. This is a major system and definitely most of the MCQs are coming from this very particular MCQ topic. So it is impossible to cover the entire topic into one portion. So we are dividing into two or three parts of the cardiovascular discussion. To begin with, the first discussion is about the chest pain. The common causes of the chest pain. Whenever a patient reported to you with a chest pain, there are most three or four causes that should come into your mind. That it can be a cardiac chest pain, it can be a pulmonary, it can be emotional, it can be neurological or musculoskeletal. So these are the all possibilities of the chest pain. For the cardiac point of view, the most important causes that are for the exam point of view, the most important causes of chest pain are basically acute coronary syndrome or the valvular heart disease in the form of aortic valvular stenosis or the mitral valve prolapse. Then is the pericarditis. These are three or four topics that are important for the exams. And the pulmonary point of view, pulmonary embolism, pneumonia, pleuritis, and pneumothorax. As we all know, there whenever there is a history of the pneumonia, uh, there is going to be some clue for the fever or infection. So that MCQ is going to be straightforward for the towards the pneumonia and excluding the cardiac causes. And among the cardiac causes, the two valvular heart diseases mostly present with the chest pain. The first is your mitral valve prolapse. Mitral valve prolapse, the scenario is given in the form of mostly females with a mid-systolic click, and there can be association diseases like Fragile X syndrome or the adult polycystic kidney disease, Marfan syndrome, and Ehlers-Danlos syndrome. That two or three points towards your diagnosis of the mitral valve prolapse. Then comes the aortic stenosis. The history of aortic stenosis is basically elderly men and the pain, chest pain that is radiating to the neck, mostly to the carotids. And there is ejection systolic murmur. There is a typical triad of the aortic stenosis, which is in the form of chest tightness, syncope, and dyspnea. So these two valvular diseases are very important for the MCQs, and these points are important for picking the important diagnosis. This is an important mnemonic you can remember as to remember the causes of late systolic murmur and the late diastolic murmur. Late systolic, basically mitral valve prolapse, is pro and he used to succeed in life, but he comes late. So late systolic murmur, succeed for systolic, late for late, and the pro for mitral valve prolapse. So mitral valve prolapse always present with the late systolic murmur, and the late diastolic murmur presents with mitral stenosis, tricuspid stenosis, and myxoma. A miss trying to steal medal. This is something very silly mnemonic, but easy to remember the causes of the late diastolic murmur. This we have discussed. Now, we use the term ACS, what you really mean by the ACS? ACS involves your stable angina, your unstable angina, and your myocardial infarction. These three diseases are covered under the topic of ACS. When a patient presents to you with a chest pain, first of all, in emergency, you suspect that patient as a cardiac patient and you label it as ACS. The most important therapy for the ACS patient is monotherapy. Mona is for M for morphine, O for oxygen, N for nitroglycerin, and A for aspirin. Among these, if the MCQ convert is the most important initial the therapy for this ACS patient, then is going to be the aspirin, because aspirin only among these medications have mortality benefit. Among these monotherapy, aspirin is the most important medicine to be given in the ACS patients. Then you should be clear cut what is the difference between the stable angina, what is the difference between MI and unstable angina. This is your coronary artery, and due to atherosclerosis there is a thrombus formation in the artery and there is narrowing of that particular artery. If there is partial occlusion of that artery, this can be your NSTEMI or this can be your angina. NSTEMI and angina are basically the same presentations. Clinically, they cannot be differentiated. They can only be differentiated by the troponin. Troponin test is very important to diagnose the unstable angina and the MI. So the STEMI is clear cut. When your artery is completely occluded, you are having ST elevation MI, and that is a straightforward diagnosis. You will find the ST elevations or the T1 inversions in the ECG. With stable angina, it's always increased with activity. So there is going to be some history that the Patient chest pain is aggravated with activity and relieved with the rest, and mostly there is a short history, less than 10 minutes, while MI is of long history, greater than 20 to 30 minutes is going to be the MI. Angina responds to your nitroglycerin, which is the initial management included in the monotherapy, but the MI don't respond to the nitroglycerin. So these are 2 or 3 points that are important when you are dealing with the patient as a frontline warrior in the emergency. Then comes the left sided chest pain, middle aged epigastric pain. Most of the time patient not only present as the chest pain, patient can present as the epigastric pain as well. Patient can present as the nausea, vomiting, profuse sweating, and if there is a mi of inferior wall, then the vagal reflexes can be initiated and patient can present as bradycardia, hypotension, and dizziness. So you should have the clear cut concept of the presentations of different type of chest pain, that it can be cardiac, it can be non-cardiac, and sometimes the non-cardiac pain which you are considering as non-cardiac is not actually non-cardiac. That is the presentation of cardiac pain. So you should be clear cut in your mind how to proceed the patient. Next, very important concept is about pericarditis. Pericarditis is the inflammation of the sac around the heart. This is the normal heart of, this is a picture of the normal heart, and this is the picture in which the sac of the heart is inflamed. It is shown as the red color due to inflammation. This is called pericarditis. Pericarditis can have a lot of causes, mostly due to infections, uremia, cancers, radiation. Uremia is called uremic pericarditis or the infective pericarditis. These are the different causes of pericarditis. It presents as fever because the infection is the cause. It presents as fever, dry cough, anxiety because it is directly related with the patient is having so much stress due to pain that they can present as anxiety, the fear of being dying, arrhythmias, and swelling of the leg, feet, and ankle in the severe cases. So these can be different presentations of pericarditis. What we are concerned most of the time is retrosternal chest pain. This pain is pleuritic in nature. This is a very important. Many a times, the question is very straightforward. If you know, you know it. That a pleuritic chest pain that worsens with the lying flat and that improves on the bending forward. This is a scenario most of the time it is given straightforward. These lines are given that the pain worsens when the patient lie flat and pain improves when the leans forward, and it can present as a coughing, swallowing. It also causes chest pain. Then on ECG you will find ST elevation, diffuse ST elevation. If you see an ECG in which your ST elevation is not following a particular lead, but there is a diffuse elevation in chest leads and limb leads, then most likely it is pericarditis. But you have to correlate with the history as well. And next important finding in ECG is PR depression. PR depression is also a component of your uh, pericarditis. Here you can see this is your isoelectric line, this is your normal line. So if we consider it as normal line, not really, this is not really a baseline. You can consider this is a baseline. From the baseline your ST segment is elevated and your PR segment is depressed. So these two are very typical for the pericarditis. How will you manage the pericarditis patient? Because it's so painful, the pain relief is the first line in management plan, in the form of NSAIDs, in the form of colchicine, and secondly you give corticosteroid to these patients. So this is important. If the pain doesn't settles with the medication, then you can also go for the pericardiosynthesis. So this is all about your pericarditis. Again, touching the electro ACS investigations. When a patient comes to you with the ACS, the first line investigation you have to do is ECG. On ECG, if you find ST elevation, this is a straightforward diagnosis of STEMI. But if you can't find ST elevation, there is a two possibilities. It can be your non-STEMI, which is EMI, and it can be your unstable angina. These two are differentiated on the basis of troponin. And among the troponin, we have three troponins: trop I, trop T, and trop C. But if someone asks you what is the most selective or the most important troponin for the cardiac manifestation, then it is troponin I basically. Troponin I is very selective for the cardiac because troponin T is also elevated in the renal diseases, in dermatomyositis, in polymyositis, that is not selective. Then another important clue for cardiac manifestations or cardiac problem is that if any patient presents to you with a new onset murmur of the patient is presenting with the S3, which is always pathological, it is a sign of heart failure, then also you should consider it as cardiac cause. It can be your cardiac ischemia leading to the heart failure. So these are the 2 or 3 important points. Okay. Next, this table is very important. You can take a screenshot of this picture. This is very important, that these are specific enzymes that are raised in the form of cardiac ischemia. CKMB, myoglobin, and troponin I. We have already discussed that troponin I is very important, but it raised in the 4 to 6 hours. If a patient comes to you, for say, patient is coming to you with a very severe chest pain which is radiating to the left arm, and it is very typical cardiac chest pain, and you ordered the tropi and it is negative, will you send the patient to the home? The answer is no. In the first reading of tropi, you should not rely on the tropi if the history is very particular for the chest pain, is very particular for the ischemic heart disease, because it takes 4 to 6 hours to raise and it takes 3 to 10 days to return. So troponin I is a very important enzyme that can give us a clue if the patient is presenting late, but very early it is not raised. In very early, myoglobin is raised in 2 to 4 hours, and 4 to 8 hours CKMB is raised. And CKMB returns in about 2 to 3 days. Most of the time, it is also returned 1 to 2 days. So, again, a question. If the patient presents to you at presentation, his CKMB is raised and the troponin I is also raised, and the patient comes to you 7 days later or 10 days later, and the CKMB and trop I is all again raised, what will be your diagnosis? It is the same infarction or it is the reinfarction? So your answer is going to be reinfarction, because it is very very much unlikely for the CKMB to be remain elevated for about 10 days. It returns to the normal in about 2 to 3 days. For if the patient is presenting at 10th day or 7th day, that is definitely a reinfarction. So these are 2 or 3 points that for MI, best test is your troponin I. Troponin I is your best test. Also a late marker for the MI. And very high troponin, there is increased mortality. For reinfarction, best test is CKMB. The most common risk factor for MI is your hypercholesterolemia, because we have just discussed that it is the atherosclerosis which is blocking the arteries and causing ischemia of the heart. And the most worst risk factor is your diabetes mellitus, because in diabetic patients there is a neuropathy, and many times they are not aware of the chest pain. In diabetics, they present with a silent MI. Their MI can be presented without chest pain. So it is very important to consider in diabetic patients, where you should be very vigilant in these patients. Then a young women mostly don't have MI. This is a perk of having being young women, unless there is a risk factor because of the estrogen support. Estrogen is basically a protective role in MI. This is an additional information. Then another important topic is about Takasubo cardiomyopathy. This is not very important for your exam point of view, but yeah, the MCQ can come because it is given in the JM that Takasubo cardiomyopathy is basically, you will have the chest pain, but there is no coronary artery stenosis or the greater than 50%. There is no evidence of plaque rupture. ECG is going to be the normal. There is absence myocarditis or pheochromocytoma. The history is very typical, that the young patient, young female most of the time, presenting with the anxiety, stress, and there is sudden chest pain, and that resolves later on. And the Takasubo, why it is called Takasubo? Because in Japanese, octopus trap is basically called Takasubo. So the heart is normally the left ventricle is like this, the cavity is like this, but in the Takasubo cardiomyopathy, the heart is like this trap of the octopus. So that's why this is called as Takasubo cardiomyopathy. And the management for this is beta blockers and ACE inhibitors. So this was another concept very important. Then we have already discussed this, that if the patient comes to you with a chest pain, first you have to do the ECG. If the ECG is normal, this is something new. We haven't discussed it. This is basically a approach towards the chest pain or the investigations towards the chest pain. Then the first line investigation is your ECG. Always ECG. If ECG is normal and the patient is very typical for the chest pain, then you will order ETT, exercise tolerance test. But exercise tolerance test has for the patient should be able to do exercise. If the patient is not able to do exercise, then what will you do? You will go for that dobutamine stress echo. Dobutamine stress echo in the form of, if the patient is not willing for exercise or not fit for exercise. This was the one category. Next is, what if you find ECG abnormality, but abnormality is not fitting into the MI category? Then you are going to do the stress echocardiography or thallium scan. Stress echocardiography or thallium scan. Again, we will revise it that if a patient comes to you, first of all, you will do ECG. If the ECG is normal, you will do ETT if the pain is very typical. If the ECG have some abnormality that is not fitting into the category of ACS, then you will do stress echo or thallium. If the stress echo comes to be positive, or ETT comes to be positive, or your dobutamine stress echo comes to be positive, then definitely you are going towards the angiography. Angiography is very important. If there is one or two vessel disease, you are going to stent placement, which is a PCI, percutaneous angiography. If there is three vessel occlusion, or the two vessel in the case of diabetics, because we have already seen diabetics present as the silent MI, then you go for the cabbage. So this is very important in the management of the ACS. Then another important concept or another important MCQ point is about the Holter monitoring. The very important thing is that most of the time students just pick up the Holter monitoring in the ACS investigation or management. This is not for the ischemia. Holter monitoring is always done for the rhythm abnormality. So this is something else, that it is for rhythm abnormalities, not for the ischemia. It can be done for the blocks or missed beat, or in the patients of valvular heart diseases that are presenting with arrhythmias or the blocks. This is not for the ACS patients. Then is a very important straightforward MCQs towards the STEMI. This is very important. If a patient comes to you with the ST elevation MI, which is the first medication you should prescribe in the emergency, that is aspirin. Patient should go for the PCI. Definitely he should go for the PCI, but before PCI, during transfer, he should be given aspirin, because aspirin is mortality benefit drug, and the STEMI patients, every second is important. So aspirin should be given at the emergency whenever you receive the patient of STEMI. Then you have to go for the PCI or thrombolytic depending upon the hospital setting. If you're working in the tertiary care hospital setting, the answer is PCI, or if you're working in the rural area, the answer is going to be your thrombolytic therapy. But the important thing is that many times students get confused between the 90 minutes and the 12-hour window period. Basically, the window period is 12 hours. In the 12-hour window period, you can go for the PCI or thrombolytic, but the ideal time is 90 minutes. So ideal is 90, but for 12 hour you can go for the PCI and thrombolytic. After 12 hour, there is no benefit of thrombolytic or PCI, because the clot has been settled in and it has become fibrosed, and there is no point toward going towards the PCI. This was all about STEMI. What about the NSTEMI? NSTEMI, you have to give aspirin, then low molecular weight heparin. Low molecular weight heparin is not going to dislodge the thrombus, but it prevents the further thrombus to be formed, prevents further episodes. So basically, it's a preventive drug, you can say. Then another thing is glycoprotein 2b3a inhibitors. This is not very important, but yeah, if the patient is undergoing stenting, or the patient is not fit to take the aspirin or other any drug, clopidogrel, then you can give the patient glycoprotein 2b3a inhibitor while waiting for the stenting or angioplasty to be done. Then this is a very important for the STEMI. We have already discussed. You will find immediately hyperacute T waves, then ST segment elevation, then the Q wave longer than 0.04 seconds. No need to remember all this. Aortic dissection is a very important topic. Aortic dissection, for the aortic dissection, you should have clear-cut concept how the patient presents, how to manage, and what are the types of the aortic dissection. If a chest pain is presenting to you with the very sharp chest pain, it is using the word tearing or ripping sensation, that is usually stated retrosternal, and it is radiating towards the back between the scapula. This is mostly aortic dissection, but the pain can also radiate towards your abdomen, to your flank or legs. It depends. But the important thing is that patient is having so severe, the tearing chest pain radiating to the back, and there is inequality of the pulses between the both arms. It can be radial, it can be femoral, it can be carotid. So inequality of the pulses and the radiating chest pain towards the back, which is very tearing chest pain. It can accompany hemiplegia, aortic incompetence, or cardiac tamponade. Investigation of choice is CT angiography. In JM, it is mentioned that the most early definitive investigation is transesophageal echocardiography. T, which is transesophageal echocardiography. If this is the option, this is the first line investigation. But if T is not given, then CT angiogram is going to be the right answer here. And there is increased risk of aortic dissection in pregnancy also. Now, types of aortic dissection, there are basically, this is your ascending aorta, then this is arch of aorta, and this is descending aorta, the three parts of the aorta. Two types of classification of aortic dissection are DeBakey's classification and Stanford classification. Stanford divides the aortic dissection into type A and type B, while DeBakey divides into type 1, 2, and 3. Your type 1, 2 of DBK is considered as Stanford A. This is same thing. And type B is considered as type 3. This is becoming complicated. You just remember Stanford classification, type A and type B. Anything which is proximal to the subclavian artery is basically Stanford type A. Anything which is distal to the subclavian artery is basically Stanford type B. Why it is important to remember type A and type B? Because the type A is very, very severe. It has to be remembered surgically. It's involving the ascending aorta or arch of aorta. It should be managed surgically. While type B is relatively mild than type A, it can be managed medically. Medically, you have two options, beta blocker and IV nitroprusside. Among these, IV nitroprusside never used first. Why? Because the patient can go into sudden hypertension and these can be very devastating. So you always give beta blocker first, then IV nitroprusside. So this was very important concepts about the aortic dissection. Lastly, we will just touch this topic, pulmonary embolism. We will go into detailed discussion of pulmonary embolism into the emergency section of MCQ or notes. Here, just a clear-cut concept of pulmonary embolism. Whenever a patient of pulmonary embolism comes in the emergency, the first line investigation is chest X-ray and ECG. It depends what to choose depending upon the symptoms he is giving in the scenario. If he gives the pleuritic chest pain, then chest X-ray is going to be the right option. If he gives the history of central chest pain radiating to the left arm, which is pointing towards the cardiac pain, then ECG is going to be the right option. Anyhow, if the first line investigation is chest X-ray or the CT, then definitive diagnosis, if asked, then first line is basically CTPA. But you all know the CTPA has some contraindication. If the patient is pregnant, if the patient is of reproductive age, specifically female of reproductive age, if the patient is very allergic to contrast media, or there is a history of the chronic renal failure, then CTPA cannot be done. In that cases, VQ scan is going to be the right option. VQ scan will be the next best investigation. Then you have many other options like Doppler sonography of the lower limbs, D-dimers, arterial blood gases, and well score definitely. So this was all about pulmonary embolism. This was the first section of cardiology. We will try to compile the cardiology segment into 2 or 3 sections.